Good afternoon, everybody. Hello. Thanks a lot for coming to our first neuroscience series as we continue with the FYI series, 08. It's great to see such a great group of people here. I want to say a big thank you to the Quad T4 task force, and then a huge thank you to Karen Saunders, who has actually put most of this together single-handedly. So I'd like everybody to stand up from the Quad T4 task force, so everybody knows who you are. Diane, Lois, Leanne, and Kim Travis. Where's Kim? I don't see her. Julie. There. So I want to say thank you. I wanted to just take a minute and introduce you to Dr. John March. He's our new faculty leader in Neurosciences Medicine. And I just wanted him to be able to stand up and say hello so you can put a face. Do you want to say something?
Only that it's delightful to see so many friendly faces. And we're going to grow Neurosciences Medicine and hope that all of you will be a part of that.
Okay, let me introduce Dr. David Marks. He is currently an assistant professor in the Department of Psychiatry and Behavioral Sciences and is one of the chief faculty members involved in the strategic planning of neuroscience division here at DCRI. He also conducts clinical trials, provides inpatient and outpatient psychiatric and pain management services, and develops curriculum for our medical students, residents, and physician assistants here at Duke. Dr. Marks came to us 2 years ago from San Diego, California, where he was the CEO and medical director of a clinical research company with sites across Southern California. He's personally served as principal investigator on over 50 industry-sponsored and federally sponsored clinical trials and has supervised the conduct of research by other investigators. Dr. Marks also actively publishes from his research and clinical work and sits on industry advisory boards. So please join me in welcoming Dr. Marks.
Thank you, Maureen. Can you guys hear me okay at this volume? Excellent, okay. So show of hands, how many are really here for the food? Okay, that's good because the intention is that we're going to have a little bit of fun today, and I want this to be relaxed and fairly open-ended, and I'm going to pause at certain points for questions during the middle, so don't feel like you have to wait till the end to ask questions. And actually, well, Karen just stepped out of the room, but I wanted to thank Karen for helping me with some of the PowerPoint issues. She's kind of a whiz with that stuff. So without further ado, this is the first in our DCRI FYI Neuroscience series. And our goal today is to introduce some concepts related to neuroscience and neuroscience research. So we're appropriately calling the talk Neuroscience Research 101. And what we intend to cover today really is an introduction to what neuroscience is in the first place and why is it important to us here at DCRI. And then we're going to launch into some real heavy lifting science. We're going to talk about some of the basic anatomy and physiology, and then some of the more applied clinical neuroscience. And finally, we'll talk about some special techniques and issues that are specific to neuroscience research. And my main disclaimer to this talk, other than I had a Red Bull about a half hour before I showed up, is as Maureen said, I'm a psychiatrist, and so later in the FYI series, we're going to be having neurologists come and speak, and some of what I'll be talking about today will be apropos for neurological disorders, but you're going to kind of pick up on a little bit of focus on psychiatry today as opposed to neurology. So, what is neuroscience? Well, that's a tough question to answer, and this is not designed to be an all-inclusive list, but this is a list of various disorders that we study in neuroscience. And as you can see, there's a lot that are here in the realm of psychiatry: mood disorders, anxiety disorders, schizophrenia, addiction, dementia, which sort of crosses the line between both neurology and psychiatry, sleep disorders, ADHD. But then, you'll also see there's a lot of neurological disorders that we study in neuroscience. Parkinson's disease, stroke, brain injury, epilepsy, and many others. And I'm sure if we sat here and put our thinking caps on, we could probably come up with many more disease states that are not on this list. But this is designed to be an introduction to these, and as the series proceeds throughout the year, you'll be getting specific talks about these individual disease states. Oh boy, are you excited about that? Okay, I know I am. So why is this important? Well, for a lot of reasons, but in terms of in terms of the Duke Clinical Research Institute, it's important to know that neuroscience has, for many years, been one of the top therapeutic areas in research. Now we're in 2008, the pharma R&D ranks it as number 2 behind oncology drugs in terms of drug development. And then, of course, number 3 is anti-infective. So we made the big 3. I wanted to say a little bit about funding sources for neuroscience research. I think you're going to perceive a little bit of a bias today. We're going to talk a lot about industry-sponsored research. But of course, there's quite a bit of neuroscience research that goes on funded by the National Institutes of Health, including NIMH and other federal organizations. There are also private foundations, such as the Stanley Foundation and the Robert Wood Johnson Foundation, that fund neuroscience research. In terms of pharma deals, again, CNS or neuroscience research has always been one of the big players. It's estimated in mid-pharma that CNS deals make up the highest revenue source. And then in terms of big pharma, it's considered second behind oncology, very, very similar to the previous slide that I showed you. And if we shift to more of the marketing and sales area of pharma, you'll see that, again, neuroscience drugs are quite a big player. I think we're number 2, 3, and 4 here in terms of sales in the year 2007. Antipsychotics, anti-epileptics, and antidepressants were among the highest revenue-producing drugs. So I say this just to emphasize that there's a lot of importance and focus going on to neuroscience treatment and neuroscience research. Okay, everybody get a breath of fresh air, because we're going to talk about some of the science involved here, anatomy and physiology. We're going to start with gross anatomy, not so much the movie, although I was kind of a Matthew Modine fan in the 1980s. I mean, I guess we all were, but we're going to start with gross anatomy, and then we're going to kind of work our way down from the macro level to the micro level. But the nervous system, from a gross anatomical standpoint, can be divided up in actually a number of different ways, but this is the most consistent way. We would view the nervous system as consisting of the central nervous system and the peripheral nervous system. The central nervous system, of course, being the brain and spinal cord. And you can further divide this down into a lot of, wacky Latin words, which I don't think are essentially important for this talk. And then, of course, the peripheral nervous system includes the somatic nervous system, which includes essentially the nerves that control motor movement and sensation in your extremities, and the autonomic nervous system, which we'll spend a little bit of time talking about these two areas. But I guess my point is everything under this arbitrary line you can ignore for now. By the way, my mom's cat loves this thing. Did anybody bring their cat today? Okay. Okay. So we're going to start. Did I miss the slide here? No. Okay. We're going to start with the brain, of course. And you could actually give several hours of talks about structure and function of the brain, and that's not my intention today. But I did want to bring up that the brain is often discussed in terms of the structural anatomy. It can be divided up into anatomical lobes in the cerebrum, and then, of course, other structures, the cerebellum, the pons, the medulla. And it can actually be divided up, and I think this is probably more relevant for today. It can also be divided up more in terms of the functional anatomy, because at this point, we have a fairly good understanding of what parts of the brain control what functions. And I don't want you to go home and immediately memorize all the structures in the brain and what they do. But it's an interesting area that neuroscience has advanced quite a bit over the last few decades. Again, this is the cerebrum, and I included, well, actually, the cerebellum is not part of the cerebrum. But I'd include it just to show that you can sort of functionally map different anatomical areas of the brain and what they're responsible for. The spinal cord, the other part of the central nervous system, the simplest way to describe the spinal cord is that it's a cable connecting the brain to the peripheral nervous system. And I think for years that's how we considered it. It was essentially, well, how do you get a message from the brain up here to your foot down here? But more and more we're discovering that there's a lot more to it than that. Of course, the spinal cord contains these axons, which essentially are acting as the cable. But it also includes gray matter, which are neuronal cell bodies and dendrites. And I'll talk a little bit more about those specific microanatomical structures. But the point of this being that more and more we've discovered that the spinal cord itself can be a target for pharmacological intervention. It's not just a cable going from the brain to the periphery. For example, we know that there are excitatory and inhibitory neurotransmitters in the spinal cord, and I'll talk a little bit more about what those are in a little bit. And there's also opioid receptors, in other words, narcotic receptors in the spinal cord itself. And so, well, why do we care about this? Well, I think around 15 or 20 years ago when this was discovered and understood, that led to a big breakthrough in the treatment of pain, for example, where we realized that we can actually inject directly into the cerebrospinal fluid at the level of the spinal cord. We could actually inject opiate pain medication and calm the experience of pain. We didn't have to just do it up here. We can do it directly at the level of the spinal cord. Now if you go to a pain clinic, you'll see that done quite frequently. You'll see spinal cord stimulators, and so it was somewhat of a breakthrough that we don't just consider the brain a passive, or the spinal cord a passive cable connecting the brain to the periphery. Okay, where is Karen here? I'm not sure what. The total time for the slideshow was 10:37. Yes. Maybe we just hit yes. Okay. Yes. All right. See, this is why I need to be handheld for these types of things. We're timing this for Best Practices website. So sorry. All right. Now, this is not working. Maybe try over here. Ah, there we go. I guess we need to set it back up, don't we? Our show stopped, Karen. If you can start it from that number 14, or this one, either one. There we go. There's the mouse. There we go. That's good. The other thing I'll say, thank you, Karen. The other thing I'll say about the spinal cord is that it's been mapped out in the sense that we know what areas of the spinal cord or what nerve roots coming off the different levels affect what areas of the body in terms of sensation or motor function, and so that's been a breakthrough in neuroscience as well. Now, the peripheral nervous system, remember that we've talked about the central nervous system, including the brain and spinal cord, and now we're going to shift gears a little bit to the peripheral nervous system. The peripheral nervous system, of course, includes somatic nerves, which can be divided up into your afferent or sensory nerves. Now, these are the ones that attach to, I'll call it your nociceptors, which experience pain, temperature, pressure, things like that, sensation. And then you also have efferent neurons, which are your motor neurons that actually control your physical motions. On the other side of somatic is your autonomic branch of your peripheral nervous system. Now this controls things like heart rate, digestion. Essentially, this is innervation to your organs. And that can be divided up into sympathetic and parasympathetic. And let me know if I'm going too quickly on this stuff, and I'll give you an opportunity to ask questions in just a little bit. But I'm going to focus in for just a moment on the sympathetic versus parasympathetic part of the peripheral nervous system. I love this picture too. The colors, it's very. I have this as my wallpaper at home. What can I say? But and I'm not sure what that's doing there. But this is parasympathetic and sympathetic. So these are the two branches of your autonomic nervous system. And the sympathetic nervous system is what we think of as that fight or flight response. So if you suddenly see a tiger or an intruder or something like that, you have activation of your sympathetic nervous system. And again, this controls some muscles and organs. And so it dilates your pupil. It pulls blood away from your digestive system, which you don't really need to be digesting food at the moment when you see a tiger. It increases your airways, accelerates your heart rate. And of course, it secretes adrenaline and noradrenaline. That's essentially your fight or flight response. On the other hand, you have your parasympathetic nervous system, which does just the opposite. I mean, this is active in more of the resting state. You just ate a big meal and you need to digest it. Well, your parasympathetic nervous system is doing that. It slows your heartbeat. It stimulates saliva, as we talked about, and it also has some effects on your bladder and various other organs. So again, I'm going through this relatively quickly, but we'll pause and get some questions in a minute if anybody has any. So now we're going to turn more towards microanatomy and physiology. Can anybody guess what year this is based on what she's wearing? Yeah, you guys are right. It was actually 1970. I pulled this from the, she's a veterinary student at the University of Kansas in the year 1970. So, I don't know. It had a kind of Marlo Thomas ring to me, so. There we go. Now, neurons are, that's the name of what we call nerve cells. And I can't see this very well, but essentially, neurons are like other cells in the body in certain ways. I mean, they have a nucleus with DNA. They have a cell membrane. They have many of the other organelles that we typically see in cells throughout the body. But they're a little bit different than other nerve cells for a variety of reasons. One of them being, they have these special processes called dendrites, which are designed to pick up signals from other nerve cells. And, they actually have this long axon that is punctuated by lots of ion channels, and that's where, as we talk in a little bit about the action potential, that's where ions flow in and out of the cell so that an electrical signal, literally an electrical signal, can be transmitted down the length of the neuron. And that's essentially how our nervous system works. That's how impulses are carried from one part of the body to the next. That's how physiological processes happen in your brain, whether it's seeing something, thinking something, hearing something. That's essentially neuroscience. I put this slide up there. I mean, it's another picture of a neuron, and it shows, the dendrites, the axon, and then this is, essentially the site where vesicles are released to the next neuron. But I think I put this specifically up there because it reminded me of something from Invasion of the Body Snatchers or something like that. I just pictured this, kind of alien. So, but I also liked it because it shows something that the other one didn't show very well. And, this is essentially a sheath that surrounds the body of the axon. And it's made of a chemical called myelin. And myelin is degraded in certain CNS disorders, the most common being multiple sclerosis. And I believe we're going to get a little bit more information about that later in the series. But what happens when you degrade this is you're really you're affecting the ability for this neuron to send signals. And ultimately, what happens is it can lead to cell death of the neuron itself. And in the central nervous system, this is called multiple sclerosis. In the peripheral nervous system, this is called Guillain-Barré. But again, we should be hearing more about that later in the series. This is just a schematic of two neurons back to back. And you can see it almost does look like a cable. This is how neurons are situated in the nervous system, and they communicate with each other really through this area right here. This is sort of the key right here. And I don't know if you can see it very well, but they don't actually connect. There's this space between two neurons. And that space is called the synapse. And it's actually very important for a lot of the things that we need to understand in neuroscience. It's highly relevant to how our neuroscience therapeutic drugs work. It's highly relevant to how drugs of abuse work. And it's relevant to CNS disease states. Now, what we'll talk about now that we've talked about the microanatomy of neurons is essentially the physiology. And to understand this, we have to at least introduce the concept of the action potential, which is essentially the hallmark of neurotransmission. I think I mentioned how the axons of the nerve cell, the neuron, were punctuated by these ion channels. And this is important to know because, as I said, you actually literally get an electrical stimulus that flows down the length of the nerve cell and then ultimately across the synapse into the next nerve cell. And during this action potential, what happens is that these ion channels open up, sodium rushes in, typically triggered by something. Now, that could be, it could be triggered by something that you touch, something that you see, something that you hear. And ultimately, these channels open in a linear fashion, one after the other, propagating an electrical stimulus down the length of the nerve cell, the neuron. And then that action potential ends when potassium outside the neuron rushes across the cell membrane through similar ion channels into the cell. That's, I don't know, it's a lot of heavy physiology, and I actually oversimplified it more for my benefit than for yours, trust me. But that's an important concept to understand in terms of how these drugs work, particularly as we get into the lectures about epilepsy and anticonvulsants and even mood stabilizing agents for bipolar disorder, because a lot of the drugs that we use work by inhibiting this process. You know, they affect these ion channels so that it's a little bit harder to get that electrical stimulus running down the length of the neuron. And now we'll focus on that space that I call the synapse for just a moment, because, again, that's a fairly important concept in neuroscience. And what happens, and you know, this is, of course, a close-up picture of the synapse. I mean, what you would have would be, to the left of the slide, where you're sitting, would be the rest of this neuron, and then to the right of the slide would be the rest of the next neuron. And neurotransmitters, which we'll talk about a little bit more in a second, are essentially secreted or released from neuron A into the space, the synapse between neuron A and B. And they act by binding to certain specific receptors. You know, there are specific receptors for each neurotransmitter on this, what's called the postsynaptic neuron. And they bind to these receptors, and then they cause the action potential in this, you know, what I'm going to call the downstream or postsynaptic neuron. Does everybody get that concept? It's very fundamental to what we're discussing. At the same time as you have this process of neurotransmitter release and binding to the receptor, you know, you also have a couple other processes going on. You know, the neurotransmitter is taken back up into this first neuron, the presynaptic neuron. And there are various enzymes that destroy it right then and there in the synapse, or even in this cell, in the presynaptic neuron in the first place. We'll talk about that a little bit more as we talk about how some of our, at least our psychiatric drugs, how they work, because they tend to work right here in the synapse, right here at this process of neurotransmitter release, neurotransmitter reuptake, and neurotransmitter breakdown. Neurotransmitters. There's quite a few neurotransmitters, and I'm not going to talk about all of them specifically. Thank you. You're going to be pleased that I'm not. But you know, there are some key ones. Acetylcholine, serotonin, dopamine, norepinephrine are the ones that we typically talk about in terms of psychiatry. But then also some of these other ones down here, the glycine and the GABA and glutamate. And I would, if I was going to classify these neurotransmitters, one of the ways I would probably do it would be to talk about how some neurotransmitters are what we call excitatory, meaning that if they bind, to a receptor, they're going to cause an action potential in the postsynaptic neuron. There we go. Okay. Is that good for people, or I can't read your faces so much to, you know, I'm not going to be able to call on you if you're sleeping, and that's what I. Okay. So again, I brought this slide back up to talk about the difference between excitatory and inhibitory neurotransmitters, but an excitatory neurotransmitter would bind to a receptor and cause an action potential in the postsynaptic neuron, whereas an inhibitory neurotransmitter would do the opposite. It would bind to a receptor and inhibit an action potential, make it less easy for this neuron to fire, let's say. So again, the excitatory neurotransmitters depolarize the neuron, and the inhibitory neurotransmitters hyperpolarize the neuron. They reduce neurotransmitter release and prevent an action potential in the downstream neuron. Glial cells, I'm not going to talk much about this, but I include it for the sake of completeness because I've talked about neurons and neurotransmitters. But you know, there are some other important cells in terms of microanatomy of the central nervous system. And these are essentially supportive cells that help the function of various neurons. They include astrocytes, oligodendrocytes, which I kind of showed you before. They myelinate the axons and provide that sheath, essentially insulation for the neuron. And ependymal cells. But what I want to point out, I think, is these astrocytes, because they're important because they make up what's called the blood-brain barrier. Is that a term that you guys have heard before? It's an important concept in neuroscience research and actually neuroscience itself. If we didn't have the blood-brain barrier, we probably wouldn't be walking around right now. We would have been completely attacked by viruses, bacteria, and other things crossing over our blood-brain barrier into our brain. But what essentially happens is these astrocytes, they adhere to the linings of your vascular structures in your brain, your endothelial cells, and they prevent certain things from crossing over from your bloodstream into your brain. Now, this is important in neuroscience research, of course, because if the intention is to develop a drug that has activity in the brain, in the central nervous system, then it needs to be able to cross the blood-brain barrier. If you're trying to develop an antidepressant, let's say, you're not going to be very successful if your drug does not cross through the blood-brain barrier. On the other hand, we have various drugs that are designed not to cross the blood-brain barrier. I remember, many years back, well, I guess it wasn't many years back, but several years back when there was a breakthrough in antihistamines. The newer antihistamines don't make you tired because they don't cross the blood-brain barrier. So they effectively block histamine in your body outside the central nervous system, but they don't cross the blood-brain barrier and make you sleepy. So that's essentially one of the importances of the blood-brain barrier in neuroscience research. For sake of completeness, there are different glial cells in the peripheral nervous system than the central nervous system, but it's all basically the same. And again, I point out these Schwann cells, which myelinate the axons of neurons and essentially provide that insulation and protection. Let me stop here for a little bit and see if anybody has any questions about this very hardcore science that we've presented thus far. Yes.
You were saying at some point in time that on this little sheath thing that potassium and sodium rushes in. What happens if the body is depleted of sodium and potassium for some reason?
Well, that's an important point. I mean, that can obviously affect neurotransmission. Just as a point of correction, sodium flows in, which is positively charged, and then sodium flows out and potassium flows in, rather. And that's if you're if you have insufficient stores of sodium, then it your ability of these structures. Obviously, all of this is dependent on having the prerequisite ions in the system. But thank you. That's a good question.
Can you turn your mic up a little bit?
I don't know. Can I? Maybe I can speak more into it.
Or try that.
I can speak louder too. Maybe that would help. Can you hear me now? All right. I feel more like a rock star now anyway, but thank you. Were there any other questions about these anatomy and physiology concepts? Yes.
I have a question. When a person has these multiform glioblastomas, does it wrong?
Every word you used was too long for me to effectively answer the question, but I'm sorry, go ahead.
Right. I just am curious, does it affect a multiple of these glial cells?
The glial cells. The question is, do glioblastomas affect more than one neuron?
Cell?
Well, my sense is that they affect the myelin. Those affect the myelin sheath that surrounds the neurons. I don't want to speak much more about it because I'm not really an expert in that area. But you're referring to the essentially cancer of the myelin sheath.
Okay.
Yeah. Yeah, doesn't actually affect the neurons themselves. It affects those supportive cells that we talked about, exactly like you say, the glial cells. And in this case, I believe it's the myelin cells, the sheath that surrounds the axon of the neuron. Yeah, no more questions with words longer than 3 syllables, please. Anything else? Okay, well, we'll proceed. Now, biomarkers, I mean, this is a concept that's getting us into the research domain a little bit, out of the straight science domain into the research domain. But you know, the definition for biomarkers that I put up there is a biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal or pathological biological processes or response to a therapeutic intervention. Now that's a mouthful, but essentially the importance of this is that sometimes when we want to evaluate I guess if we want to evaluate for pathology in neuroscience, or for a therapeutic response in neuroscience, we will use these surrogate markers. Some of them might be looking at, whoops. All right, well, Karen. Well, I can get it from here. Okay. All right, biomarkers, take two. So, you know, we've come to understand that there are certain physiological markers of disease and certain physiological markers of improvement in disease. One of the chief areas, of course, we're interested in is genetics, genomics. You know, there are certain genetic markers, or sometimes what we'll call polymorphisms, that we think are linked to certain disease states. Now, in some diseases, it's very clear that certain genetic mutations cause disease. In other cases, it's not so clear, and you know, we think that it happens in some folks, but not in other folks, or maybe you need a multitude of these types of genetic mutations to actually cause disease. But sometimes we will be looking at DNA in patients with CNS disease. Sometimes we look at proteins that are created from DNA in these patients with disease. And then sometimes we do these various electrophysiological measures or actually other sort of tests that you can run. Neuroimaging is, of course, one. I mean, obviously, certain diseases are associated with abnormalities in brain structure that we can detect with our imaging methods. Some disease states produce changes in the electroencephalogram, which is certainly something that you'll hear more about in the neurology lectures. But I'm going to talk a little bit about neuroimaging specifically, because it's been a very big area in neuroscience research now for a number of years, and I just use it as an example of a biomarker. Neuroimaging, there's a lot of different strategies for neuroimaging at this point. Some of them are structural, in the sense that if we obtain an image of the brain, we can look at, just in real time, we can look at what structures of the brain are normal or abnormal. Obviously, if you suspect that there's some physical lesion of the brain, this is the way to go. Strokes, of course, will show up typically if you do a structural scan of the brain, a structural image of the brain. But we've also developed techniques to look at brain function. We're able to essentially measure what areas of the brain are oxygenated or receiving blood flow, and it's not really used clinically as in the sense that the structural images are, but certainly in the research settings it's been very useful and interesting to try to figure out what parts of the brain are active during certain tasks and inactive during those tasks, what parts of the brain are more active in patients with a certain disease state versus in the absence of that disease state. Can you guys hear me okay now? Okay, good. There's other techniques. I mean, the ones that I mentioned are, of course, the structural MRI, which is just what you think of as, when your doctor orders an MRI. Then there's the functional MRI, which is what I mentioned in terms of actually looking at blood flow or oxygenation of the brain. There are also SPECT scans and PET scans, which we've used in the research setting. And again, these tend to measure physiological activity of the brain. But also, these also provide kind of a unique thing for us too. We can actually look at what neurotransmitters are active, or we can look at what areas of the brain are using what neurotransmitters using these imaging techniques. I like this picture. This was just an example of a functional MRI machine. It's fairly similar to a structural MRI machine, but if you've ever heard people say that they don't want to get an MRI, or they're scared to get an MRI, or they're claustrophobic so they don't want to get an MRI, I mean, you can kind of see why. Patients actually, they enter this way and they're in this very small tube and it's very loud. Did you have a question?
Yeah, I was just wondering, you were mentioning that you could track the activity of some neurotransmitters during some of the MRIs, and I was wondering, do you have to administer something so that the different neurotransmitters are flagged somehow? I mean, how do you tell the difference between norepinephrine and epinephrine or serotonin or?
Yeah, that's a good question. You do have to. Can you hear me with this mic? Okay, you do have to flag the neurotransmitters some way. You know, oftentimes they're radio labeled, and so yeah, that's a good point. I mean, it's not a quick and easy procedure. It requires typically, you know, injections of radio labeled neurotransmitters or precursors of neurotransmitters in order to administer a test like this. It's not done clinically. I mean, it's not really used to diagnose something at this point, although that may be around the corner. I mean, it's more used in research settings. Yes.
I've had an MRI. That's a scary proposition. How do you weigh that when you're looking at like your transmitters, your norepinephrine and epinephrine transmitters? What effect does the patient's actual presence in that tube? How do you differentiate that between what you're studying?
That's a very astute question. In other words, does just the fear of being in the MRI machine produce a signal that sort of confounds the assessment of what you're studying in the first place? I don't know that I have a great answer for that question. I mean, typically, you know, the paradigms that are used, you know, have typically there's a pre-state and a post-state, and so, you know, you would expect, if there was some kind of a confounding signal, you would expect it in the pre-state and the post-state. I'm not sure what area, you know, I guess, you know, you might expect that, you know, the amygdala or certain structures associated with fear would be more activated in patients that are experiencing this. But I don't really know the body of research related to whether, you know, there are confounding factors of just fear with the MRI state itself. You know, it is a real clinical issue. I did a consult at Durham Regional Hospital yesterday, and, you know, we were trying to figure out how we would adequately sedate a patient that was about to have a CAT scan of their chest to look at whether they'd had a pulmonary embolus or not. And so, I mean, it's certainly something, you know, this issue of the fear of the machine comes up in clinical situations as well as the potential confounds of research. This is a structural MRI, and I show it, you know, essentially just to, you know, some of you may or may not have seen them before, but it's pretty neat. I mean, you know, you have a pretty good feel for the structure of the brain, and obviously, you know, it's used, as I mentioned, in the case of strokes or tumors, and it provides pretty good resolution for seeing a lot of the fine structures of the brain. This is a functional MRI, and, you know, as I mentioned before, it allows you to see what parts of the brain light up during certain tasks. Or, again, if we were using more of a PET scan, which I think I have a PET scan as well. Yeah, here's a PET scan. You know, the PET scan shows what parts of the brain are active in certain tasks as well, but also, as I mentioned, what you know, certain neurotransmitters you can label. In this case, that would be dopamine, and this is the brain of a unaffected patient, and these are brains of patients with Parkinson's disease prior to the administration of, I believe it's labeled dopamine or L-Dopa as the drug that's used clinically. And you can see that there's a difference between the pre and post treatment with L-Dopa in Parkinson's patients. It starts to look more like a normal brain. You have much more activity. In this case, I believe those are the structures of the basal ganglia. But that's how, you know, and that issue is not so important in itself, but I show it just to exemplify how these types of images are used in research settings. I thought this was interesting. This is this comes from a functional MRI scan of blind patients who are reading in Braille. And I think the relevance of it, I guess you might sort of ask yourself, well, what parts of the brain are active in a visually impaired patient who is reading with Braille? And it turns out there is activation of some of the visual cortex. I mean, some of the same areas that are activated when a non-visually impaired patient reads by sight. Again, that's not the concept I wanted to point out as much as just, these are sort of interesting ways that these techniques are used in the research setting. All right. We're going to shift to more of diagnosis and treatment, largely of psychiatric disorders, like I suggested. Does anybody recognize what this picture is? Okay. What is it? Yes, Diagnosis Murder. My mom was a big fan of that show, so I thought I'd put that up there. How about this one? Do you guys know this one? Very good. Very good audience. Yes, St. Elsewhere, I guess that's Denzel and Howie Mandel and Mark Harmon. Ed Begley Jr. Quite a cast. So, as I mentioned, why don't we talk about the diagnosis of psychiatric disorder? And this is a stack of the Diagnostic and Statistical Manual of Mental Disorders, which is, I don't know, sometimes you hear it in the vernacular called, it's the Bible of psychiatry in a sense. It contains the diagnostic criteria and a little bit more information, but largely the diagnostic criteria for the various psychiatric disorders that we diagnose. There's not a DSM-1, there's a DSM-2 up here, and you can see it's basically a pamphlet, and compared to DSM-4 here, and then this is a text revision, but compared to DSM-4, things have changed quite a bit. Just to highlight that, in 1952, with DSM-1, there were 106 disorders identified, and by the time we have DSM-4 in 1980, there's 265 disorders, and of course it's much thicker. I don't know, I don't think that reflects that, people are generally sicker or crazier, so to speak. And I think, this is a result of neuroscience research. I mean, we have better identified and characterized the phenomenology of mental disorders. We've done just with research over time, we've done a better job of identifying, what types of aberrant behaviors should be clustered into disorders that are diagnosable and treatable. This is probably one of the first conversations I have if you're one of my medical students, other than why are you 15 minutes late and where's my chai tea latte? But, it essentially, if you've ever seen a chart on a psychiatric patient or something like that, we tend to use this multi-axial system of diagnosis. And this is straight out of the DSM, where diagnoses are labeled on axis 1 through 5. Most of the diagnoses that we see, treat, and do research on are considered axis 1 disorders. That's depression, schizophrenia, anxiety disorders, Alzheimer's disease. I mean, these would all be considered axis 1 disorders. Axis 2 disorders include mental retardation and personality disorders. Oftentimes in neuroscience research, we want to rule out patients that have what we call personality disorders, just because they tend to be a little bit treatment refractory, and they confound the assessment of the axis 1 disorder we're trying to study. And then, for the sake of completeness, axis 3 are medical conditions, axis 4 are stressors. That's important really in the clinical setting, because those of us who do treatment in mental health, we want to do more than just try to correct brain chemistry. I mean, we're really trying to address the person's biological but also their psychological and social needs. Yes.
I was wondering why axis 2, like why those two were kind of lumped together. Is there a reason why?
Well, mental retardation and personality. Well, we do have a child psychiatrist in the room, which is, we can always defer to him. But they seem a little arbitrary in that they're grouped together. But by definition, it's considered disorders that began in childhood. And there are other disorders that began in childhood, like attention deficit disorder, that we have on axis 1. But the premise of this is that these are disorders that began in childhood, and they're generally sort of fixed and not fluctuating or episodic. Well, I only know a handful of them, and none of them fit that bill, but I'll study you over time, and we'll make that assessment. Is that an okay description of the answer to that question? Or?
The short answer is that none of this makes any sense. 25 years from now, we'll all be gone. We'll have a whole different way of thinking about these things based in neuroscience, but the derivation was, as David said, personality disorders and mental retardation are static, and the axis 1 disorders come and go.
Thank you very much. And then axis 5 is the global assessment of functioning. I actually had that in the handout, and I think I think it's in your handout, but I took it out of the slide set because I didn't want people to get overly focused on that. But it's essentially a numerical score that we assign patients in terms of, how well are they doing functionally. I mean, it gets us out of that mode of, focusing on symptoms or disorders and into the mode of, well, how well is this person doing? And it's kind of nice because it crosses, it doesn't matter whether you're depressed or psychotic or having dementia or attention deficit. I mean, it's the same scale that's used for all disorders. Yeah, I did take it out of it, but it's in your handout if you wanted to see it a little bit more closely. I also included just a few pages from the DSM for mostly just to show you how it works and what it really means to have criteria for a specific diagnosis. For example, these are the diagnostic criteria of attention deficit hyperactivity disorder from the DSM, and typically with these disorders, you have to meet a certain number of these symptoms. In this case, there are different symptoms of hyperactivity and inattentiveness. But the other thing about the diagnoses in the DSM is that by definition they all bring with them a certain amount of clinically significant distress or impairment in functioning. I mean, if we're going to try to diagnose something and call it a disorder, it needs to have some problems or morbidity associated with it. So for example, with attention deficit disorder, there must be evidence of clinically significant impairment in social, academic, or occupational functioning. Sometimes also in the DSM you'll see these criteria that include that these symptoms are not due to a medical condition, they're not due to a drug of abuse or a medication, or they're not due to a different axis 1 disorder that could be causing this. Again, these are other pages from the DSM. These are, for example, the criteria for pathological gambling and substance dependence. Nothing that, I don't know that we're going to have a specific talk on pathological gambling, although it's a very exciting and interesting disorder. But, we are actually going to have a talk specifically on substance use disorders. So I don't want you to learn the criteria and, have a report on my desk by tomorrow morning. But, it's interesting to just see how the pages flow and how, we end up diagnosing these disorders based on criteria. They sometimes seem arbitrary. For major depressive episode, for example, you have to have 5 out of 9 criteria for depression, and that's not to imply that, well, if you have 4 that you're not depressed, or that if you have 6, well, you're extremely depressed. But I mean, it's we've come to learn through neuroscience research that certain symptoms cluster together and that they predict long-term difficulty in mental disorders and that they're treatable, and that's essentially where these diagnostic criteria come from. So that's diagnosis. I went over it fairly quickly, and we can always entertain questions, but I'm going to shift gears a little bit and talk about treatment for psychiatric illness. And this is not an all-inclusive list of treatments for psychiatric illness, but we're going to focus, of course, a lot on psychopharmacology, being that we're here to talk about research, and there's a little bit of my experience is largely in industry-sponsored research. But of course, there's a lot of research that goes on in psychotherapy as well. For completeness also, psychiatric treatments include electroconvulsive therapy, what you might hear as shock therapy in the lay press, transcranial magnetic stimulation, which is, similar in some ways to electroconvulsive therapy, even psychosurgery, which is, rare at this point, and deep brain stimulation. And, I left a few treatments out, but, when I sort of think in terms of globally what represents psychiatric treatment, this is what I tend to think of. So psychopharmacology, unfortunately, I'm going to bring you back to some of the physiology that we talked about a little bit before. But I'm going to go through some of the main types of psychopharmacological treatments and talk a little bit from a physiological standpoint about what they do. It's relevant in terms of going forward with the series as well. And I'm going to start with what I have in quotes as antidepressants. And the reason that I have them in quotes is because we call them antidepressants, but in a sense, what they do in a physiological standpoint has been shown to be effective for a wide variety of disorders, depression, of course, but also anxiety disorders, pain syndromes, and actually probably some other things that I can't think of right now. But, and we'll see the same thing with some of these other classes of medications. But antidepressants tend to be divided up according to what they do physiologically. For example, we have selective serotonin reuptake inhibitors. We have serotonin norepinephrine reuptake inhibitors. We have an older class called tricyclic antidepressants, an older class called monoamine oxidase inhibitors, and then a variety of other agents that work by miscellaneous mechanisms. But if I look at that a little bit more closely, what these reuptake inhibitors are doing, as I mentioned before, when you have a presynaptic neuron communicating with a postsynaptic neuron across the synapse, the way it does that is by releasing a neurotransmitter into the synapse. And then this neurotransmitter, binds to the receptor, but it's also taken back up into the presynaptic neuron by one of these transporters. And the selective serotonin reuptake inhibitors block this reuptake of serotonin into the presynaptic neuron. The effect of that is that the serotonin lingers in the synapse and essentially provides more of a signal to the postsynaptic neuron. It leads to further depolarization and action potential. I'm using buzzwords that we learned about 20 minutes ago. It causes an action potential in the postsynaptic neurons. So it essentially, this is how the signal occurs. And reuptake turns off the signal. Selective serotonin reuptake inhibitors block the reuptake of serotonin, whereas serotonin norepinephrine reuptake inhibitors, they're a little bit broader. They block the reuptake of serotonin and norepinephrine from the synapse. So, sometimes that means they have a little bit different uses. What I haven't talked about is, well, what do these various neurotransmitters do and what are they linked to? One example of that would be that it's believed that certain pain syndromes respond better when you block the reuptake of serotonin and norepinephrine instead of just serotonin. But the important take-home point that I wanted to make is just, that's what these agents are doing. They are preventing the neurotransmitter from being cleared from the synapse, and that is the therapy. That's believed to be the therapeutic effect of these medications for a variety of different disorders. Tricyclic antidepressants, it's an older class, but we still use them for a lot of different types of disorders. They essentially block largely norepinephrine, but also to some extent serotonin from the synapse. We're going to shift gears a little bit with monoamine oxidase inhibitors. Monoamine oxidase is the enzyme that breaks down these neurotransmitters, serotonin, norepinephrine, and what the monoamine oxidase inhibitors do is they prevent this enzyme from degrading the neurotransmitters, and again, that keeps the drug around in the synapse longer too. And these enzymes occur within the neuron and then outside the neuron in the synapse as well. So the commonality of these drugs is that they're designed to keep the neurotransmitter in the synapse for longer and more neurotransmitter in the synapse. Yes?
There she is. Why is it when you start taking medication, say for anxiety, you can never get off from it?
Well, the medications you're talking about, I'm actually going to show on the next slide. If you start taking, I think what you're referring to is that certain medications are, I don't know, maybe you develop a dependence on, maybe you develop a tolerance to them, and that if you go off them, you may have withdrawal symptoms from going off the medication. Yeah, that's. You're referring specifically to a class called the benzodiazepines. Those are your Valium, Ativan, Klonopin type drugs.
No, actually, I'm referring to something that's an antidepressant, but also classified for anxiety. Okay, and I have tried when I felt like I didn't need it for anxiety any longer to stop, and when I did, I found that I was having anxiety all over again. So it's kind of like I'm addicted to it. I can't get off from it.
I see what you're saying. Well, my sense of that is that anxiety disorders tend to be chronic in nature, and these drugs that we're talking about, they're not what I'd call disease-modifying drugs, and I have a slide that I'll talk about that in a little bit. But they're not designed to cure the anxiety. They're designed to control the anxiety. And, it's almost like having diabetes and needing insulin. I mean, if you go off insulin, your blood sugar is going to go back up if you're diabetic. And, that doesn't mean that, you're addicted to insulin. But, these symptomatic drugs that are designed to prevent the expression of anxiety disorders, unfortunately, if you go off them, you're going to have a recurrence of the anxiety symptoms.
Why do they categorize antidepressants for being depressed and anxiety? Why isn't there two separate? See, I have a hard time wrapping my mind around the fact that I'm not depressed, but I still need the medication for anxiety.
Well, that's part of the problem with calling these drugs antidepressants, is that I think we've sort of bought into that's what these drugs do. But it's very clear that in the absence of depression with just anxiety disorders, these same medications are effective. And, depression tends to be episodic, but anxiety disorders tend to be fairly chronic. And, if you have an anxiety disorder and you go off the treatment, much like I mentioned with the diabetic and insulin, you're going to have a recurrence of the anxiety. And that doesn't mean that you're depressed. It just means that, the medication that was used to treat your anxiety is no longer doing its job. Some of the medications used to treat anxiety are, I'm kind of going down to the bottom of the slide, but, these are more sedatives, these benzodiazepines. But, and again, I don't think that, we need to memorize all the drugs, but what's relevant about these is that they work by helping the binding of an inhibitory neurotransmitter. And so remember I mentioned how some neurotransmitters are designed to cause neurotransmission, whereas other neurotransmitters are designed to inhibit neurotransmission. GABA is an example of a neurotransmitter that's designed to inhibit neurotransmission. These types of drugs, unlike the ones I showed you a minute ago, work actually very quickly, and they're what we consider as sort of tranquilizers and sedatives. Similar to the issue with antidepressants that you brought up, where we call them antidepressants, but they work for a whole lot more. The same issue is unfortunately true of what we call antipsychotics, and that's why I have it in quotes as well. These are drugs that originally came out with the purpose of treating schizophrenia or, reducing hallucinations, delusions, and paranoia, and thought process disorganization. But as it turns out, they also help with bipolar disorder. They help in some ways with depression. They help with delirium, and sometimes in behavioral problems in autism and a variety of other types of issues. And just to cover them briefly in terms of their physiology, now these actually block neurotransmission of dopamine. These disorders that I just mentioned are believed to occur from having excess dopamine in certain pathways of the brain. And so if you block that at the level of the receptor, you're going to block neurotransmission, and that's the effective treatment for some of these disorders. I'll mention mood stabilizers, and I think, to segue with the neurology, I think anticonvulsants, which are in themselves mood stabilizers, but also, of course, used for the treatment of epilepsy, are worth mentioning as well. What these drugs tend to do, I mentioned this some before, but what these drugs tend to do is they inhibit this action potential from going down the neuron. They tend to block or inhibit these ion channels, and so by doing that, they sort of stabilize the membranes of these neurons and prevent neurons that are maybe hyper-excitable, that are firing that shouldn't be firing. They prevent that from happening. I put this up to remind myself, actually, to talk about a point that we've covered a little bit already, but it's the difference between symptomatic and disease-modifying therapy. A lot of the treatments that we just talked about would be considered symptomatic treatments in the sense that they don't cure the disease. And maybe since I talked about diabetes, I'll use that as an example. I mean, insulin, for example, would be a symptomatic treatment in a sense of diabetes, and the fact that you don't take insulin and have it cure your diabetes. On the other hand, more and more, not just in neuroscience, but in other fields as well, we're looking at disease-modifying therapies that are designed to actually target, really the fundamental, pathological process in the disorder. An example of that might be in Alzheimer's. At this point, we have a good understanding about what the at least what's going on physiologically with Alzheimer's. You're developing these amyloid plaques and neurofibrillary tangles. And while I could give symptomatic treatment of Alzheimer's disease, maybe by giving what's called a acetylcholinesterase inhibitor, I can try to reduce the expression of Alzheimer's disease. I'm not modifying the disease, but I think on the horizon are drugs that will actually prevent the amyloid plaques and neurofibrillary tangles of Alzheimer's disease and actually prevent it from occurring. Something similar is going on in a disease called Fragile X, where we're in development are drugs that will actually prevent the expression of the disease state in itself. So I'm hoping that you'll hear a little bit more about this in the individual disorders by future speakers as they come on. But it's just an interesting concept that I wanted to bring up today. So that's almost all that I wanted to talk about related to treatment, except that I have a couple of interesting slides. This is bathing therapy, which was very popular in the late 19th century up through the 1940s, where patients who were agitated or probably psychotic as well were put into these baths for several hours or even several days as a treatment of their agitation and their psychosis. Similarly, this is a frontal lobotomy, a transorbital frontal lobotomy, I guess. They're going in through the orbit of the eye to basically cut some connections from the frontal lobe to other areas of the brain. This was very popular. I guess it was developed in the 1890s and was very popular up through the 1940s and 50s. 40 or 50,000 people got this in the United States. Actually, there was a Portuguese neurosurgeon who worked on the technique quite a bit, and he won the Nobel Prize for Medicine for his contribution to frontal lobotomies. I think that was in 1945. Antonio Muniz was his name. So I show these, not to be shocking or to, frighten people, but, these advancements in neuroscience research have done a lot for science, but they've done a lot for society and essentially for the ethical treatment of patients with mental disorders. Questions? We're probably about 2/3 or 3/4 done at this point, so. Okay, well, I will proceed. Let's talk about a little bit of neuroscience research. And, my understanding is that most of the people here have had some experience with research, perhaps not neuroscience research, but, I'm going to talk about some of the things that make neuroscience research unique and, some aspects of design and methodology that if you haven't done neuroscience research itself, that, may be new concepts for you. So the first would just be, and again, this is, my bias is that I'm going to talk about some of the types of industry-sponsored research that we do. But this is the schematic of what I'm going to call an acute phase trial. This is the design overview of how an acute phase trial of a medication for a psychiatric disorder might go. This might be an antidepressant. This might be an antipsychotic. This might be a medication for a pain syndrome. But the way it works tends to be this, patients, and I bring it up because there's some key issues I wanted to bring up. Patients often go through what I'm going to call a single blind placebo run-in. Has anybody heard that term before? The idea is that, when we're doing this trial and we're wanting to look at whether there's a difference between the drug we're wanting to study and placebo, we want to weed out some people that might be apt to respond to placebo. That's a controversial issue. We're not really sure whether it's effective in doing that or not. But frequently patients undergo this single-blind placebo run-in where everybody gets placebo. Those who had a therapeutic response to placebo are eliminated from the trial. Those that are still symptomatic are randomized into the double-blind trial. Now, double-blind, is that a term that people are familiar with? Okay. The other thing I wanted to bring up is this particular trial, in addition to being an acute phase trial, could be described as a dose-finding trial because what's being tested here is placebo versus 3 different doses of the study medication with the idea of trying to figure out which dose of the study medication is the most effective and the most tolerable. In this particular case, that's done over 14 weeks, but there's nothing unique about that time frame. In contrast, this is an example of what I call a maintenance trial or a relapse prevention or durability trial. In this case, patients are stabilized open label with the medication of interest, and then those who responded to the medication. This time, we're going to randomize people who did respond. Those who responded to the medication are then maintained, this time longer term, more like 6 months. They're maintained on the medication versus placebo with the idea of seeing, well, who gets worse? Who has a relapse, whether it's depression or pain or schizophrenia. And so that's why we call it a relapse prevention. What we're interested in is determining whether there's a difference between the study drug and placebo in terms of the number of people who have a relapse and, into having symptoms. Now, I wanted to bring up certain diagnostic assessments, and we don't use a lot of diagnostic assessments in the clinical setting very much, but in research settings they tend to be crucial for psychiatric research, and they're used to confirm that patients meet the diagnostic criteria for inclusion into the study itself, and that they don't meet any exclusion criteria, i.e. diagnoses that would be excluded from the study. And they tend to be administered by experienced clinicians. Typically, a psychiatrist or a psychologist would be asked to administer this. Some examples include the mini international neuropsychiatric interview, the mini, or the SCID, the structured clinical interview for diagnosis. I included just a one page from the SCID. This is related to anxiety, I think a panic disorder. But what you tend to see is, there are literally word-for-word questions that you can ask if you want, but it's still incumbent upon you to decide whether the patient meets the criteria for that specific symptom. That's why they tend to be administered by people who have a good bit of clinical experience with the disorder. So those are diagnostic measures. There's also efficacy measures, and efficacy measures are usually the main endpoints of the study itself. When we're talking about, for example, in the previous slides, does the drug work better than placebo? What we're talking about is, does it have a better signal on the efficacy measure? One, specific to neuroscience research or psychiatric research, in contrast to maybe something in cardiology or renal disease, we're not really following lab parameters in terms of efficacy or blood pressures and things like that. I mean, we're following scores on these validated rating scales that are specific to the disorder in question. Now, some of these efficacy measures are rater scored, meaning that somebody would administer the interview to the patient and they would score the patient. That's typically what serves as the primary efficacy measure for these psychiatric studies, rater scored scales. There are some exceptions to that. For example, some of the pain studies, they would use self-reports of pain and things like that. But by and large, with psychiatric research, you tend to see these rater-scored scales serving as the primary efficacy measure. I gave a list of several of them for various disorders. There's nothing, specifically unique about these. But one thing that I would point out is that, typically you have to score high enough, but maybe not too high on certain scales in order to be eligible to be in a study itself. If you're doing a study for depression, for example, to enter the study, you have to have a high enough score on one of these depression rating scales. What for some people that have had experience with this, I would just point out that one of the things that we've seen over the years is a strategy used where a different scale is used as the entry criteria as opposed to the one that's going to be used to determine whether there's a drug placebo difference. I think there was an issue with bias caused by investigators kind of squeezing people into studies by maybe altering the score just a little bit, and we've gotten around that by kind of unlinking the inclusion criteria scale to the primary efficacy measure scale. And I went through that pretty quick, but we can talk about that more if people have an interest. I include this as an example of, this is just one item from the positive and negative syndrome scale that's used in schizophrenia. But I like it. This is kind of my favorite scale for some reason. And I guess the reason why is because this is a item specifically to delusions. And so the rater is asked to interview the patient and rate the patient in terms of their severity with a number score. But there are these various anchor points that the rater can use to guide them whether they're going to call this mild or moderately severe or extreme. And I've always really liked the positive and negative syndrome scale because I like the anchor points that are used. Here's a similar one. This is the Montgomery-Åsberg Depression Rating Scale, and it has kind of a unique feature because you can rate the patient in between the anchor points. So let's say you're seeing a patient and you would say, well, I don't know, I think they're a little more severe than, than sad or low, but brightens up without difficulty. But yet I wouldn't really say they have pervasive feelings of sadness or gloominess. I'm going to rate them as a 3 in between these 2 anchor points. So that's kind of a unique feature of that scale that I've appreciated over the years. For completeness, this is just the full Montgomery-Åsberg depression rating scale. So I talked about rater-scored scales, but there are also these self-report scales. A lot of times those are used as secondary efficacy measures in psychiatric studies. But as I mentioned, there are some exceptions to that. Pain studies tend to use self-report of pain, oftentimes just a simple visual analog scale where a patient is asked to kind of put a mark on a line that reflects, no pain at all to the, worst possible pain. Insomnia studies, when we're not actually measuring their brain waves during sleep, oftentimes we're just measuring how they say they sleep in sleep diaries. So sometimes self-report scales actually do serve as the primary efficacy measures. Oftentimes these self-report scales are used to assess symptoms that are related symptoms, but not really the core symptoms of the disorder studied. For example, a fibromyalgia study, that is interested in the outcome of pain, might use self-report scales for fatigue or for impairment in cognition and memory and things like that. Oftentimes, these self-report scales are used to capture functional change as opposed to change on the actual target symptom of the study. Or quality of life. There's been a movement over the last several years that when we're doing neuroscience research, we need to be paying more attention to functional issues and quality of life as opposed to just simply an improvement on a scale that measures psychosis or anxiety or attention deficit or something like that. So you'll see a lot of these self-report secondary efficacy measures that deal with quality of life and enjoyment and satisfaction or disability, things of that nature. This is an example of a self-report. This is the hospital anxiety and depression scale. But as you can see, the reader is asked to basically make a mark by the anchor point that describes how they feel. Another movement that's happened over the last several years really has been to capture a global sense, kind of a gestalt sense of how is the patient doing. And so, we have a lot of global impression scales. Again, these are typically used as secondary efficacy measures in neuroscience studies, but they capture the overall impression of severity or improvement. And, they can either be investigator scored or self-report. The common one is the CGI, the clinical global impression of either severity or improvement. But there are also these self-report scales, such as the patient global impression scale. I have an example of the clinical global impression scale. This is rater scored or investigator rated, where it's fairly straightforward, but the investigator is asked to decide whether the patient is either normal, not at all ill, or among the most extremely ill patients. And then in terms of improvement, they're asked to assess whether they're very much improved or very much worse, anywhere along that continuum. I included this just to show that there has been some efforts to try to put anchor points onto the CGI so that the investigator isn't just thinking, well, are they mildly impaired, or are they mildly improved? Maybe I need a little bit more description to guide that judgment. So this was a publication years back in CNS Spectrums that had the intention of putting some anchor points onto the clinical global impression. So we're almost done. All I really wanted to do at this point was just look through the inclusion-exclusion criteria of a typical CNS study or neuroscience study. This in particular, this one is a schizophrenia study, and just see if there's anything unique that stands out to people in terms of, having not done neuroscience studies, I haven't really seen that before. So when we go through it, most of it's fairly straightforward, and you're probably used to seeing inclusion criteria and exclusion criteria for studies. More and more we're seeing consents done for genetic testing because, as I mentioned in the biomarker piece, we're interested in what genetic polymorphisms are linked to psychiatric disease. Of course, they have to have a DSM diagnosis of the disorder in question. In this case, they had to have a score on the positive and negative syndrome scale, which I had talked about, of between 70 and 120. So, you know, they wanted people who were ill enough that we could detect a signal, but not so ill that they were inappropriate to be in a placebo-controlled study. You know, there were some criteria medically, including they needed to have a particular body mass index. You know, at like most studies, they pay a lot of attention to making sure. Yes.
I just got a quick question.
Yes.
Isn't the fact that somebody's diagnosed with an axis 1 mental disorder, schizophrenia, doesn't that somehow exclude them from signing an informed consent?
So I don't know if everybody heard that, but the question was, does having something like schizophrenia preclude you from signing informed consent in the first place? I mean, that's a very important question and an important issue. You know, that's been debated throughout the years, and I mean, typically, you know, according to good clinical practices, it's up to the investigator to decide whether the person adequately is able to understand the informed consent. I mean, informed consents, you know, are you know, written, you know, such that, you know, it's a fairly simplified language so that patients can understand it. I've seen patients in my research practice over the years that I thought that wanted to participate, that I thought did not adequately understand the study well enough to participate related to their psychosis. But, you know, you see many patients who, despite having maybe, you know, delusions of being poisoned and hearing voices, are still, you know, quite cognizant of what they're doing and are able to participate in a study like this. Sometimes IRBs asks that, you know, internal review boards ask that very question that you raised, in the sense of, is this a vulnerable population? Is this a special population that should be treated differently? And a lot of times we need to specify that with the IRB, that we're studying a vulnerable population. At this point, the answer to your question, I would say, would be that, you know, no, having psychosis does not preclude you from being able to provide informed consent. However, you know, the investigator needs to use good judgment when deciding whether somebody appropriately understands the risks and benefits. This is all fairly straightforward in terms of inclusion criteria. Now this is a little bit specific to, this is sort of related to the question that you just raised and specific to certain types of neuroscience research. You know, patients have to have the right to legally consent to participation in a research study. And, you know, more than once I've had patients who, although they wanted to participate and might have been an appropriate participant, they were legally on, well, I guess what in North Carolina would be guardianship, but they did not have the legal right to enter into contracts such as this. And so, you know, that's sort of something that, you know, if you don't have your eyes open for that, you may kind of get blindsided by patients who actually do not have the legal right to consent to participation in a study. Again, you know, in the exclusion criteria, we also have that they have a diagnosis other than schizophrenia. So that would be the premise of doing one of those diagnostic scales at the initiation of the study to make sure that they don't have a diagnosis that would be excluded. Oftentimes we have exclusions for active substance dependence. You know, we have exclusions for treatment resistance because, you know, if what we're trying to do is detect a signal in terms of efficacy, you know, we don't want to include patients that have been very difficult to treat over the years. And then again, as I said, there are various exclusions related to medical status and labs as well. Okay, we have a few minutes left, and so I'd be happy to entertain any questions. And Karen was out of the room, but I wanted to thank Karen for helping me with my PowerPoint slides. Any burning questions? Okay, well, I thank you for your participation. I've enjoyed it, and we'll come back and do more of these, so stay tuned.